All right, so now we've talked about the vestibular system and sort of how it works, and we're going to start talking about vestibular system disorders. So the most common symptom of vestibular system dysfunction is vertigo. So vertigo is an illusion of motion. So sometimes you have physiologic vertigo and pathologic vertigo. So physiologic vertigo occurs when there's sensory conflict, either between one sense and another. The really good example of this is, I think we've all experienced, you're sitting in a car that's not moving, maybe in traffic, and the car next to you starts to move forward, and it feels as though you're moving back. So basically you're getting a conflict between what you see and what your inner ear is sensing. And that gives us that illusion of motion. So it's a normal occurrence. But when you have a pathologic vertigo, it occurs with both peripheral and central disorders, and it arises from disturbance of spatial orientation in the vestibular cortex. So it's a sudden imbalance of vestibular signals, and it's usually caused by a lesion of the vestibular apparatus, the vestibular nerve, the vestibular nuclei, or the cerebellum. So just like we talked about with somatosensory lesions, you can have ataxia caused by peripheral sensory loss, vertical tract loss, or loss in the cerebellum. It's the same thing with the vestibular system. Vertigo can be caused by peripheral loss, something in the nerve or the vestibular nuclei, or in the cerebellum. So that's what the evaluation and examination of vestibular disorders involves, is trying to tease out what is the issue. So chapter 23 is about dizziness, and it's all about really vestibular evaluation. So we will not be covering it in this course, but it's nice to use as a reference in the future. Vestibular treatment is not generally considered an entry-level PTA skill, but it's something that you might pursue in the future. So there are lots of things that are not considered entry-level, but later on, as you gain more experience and you start to find your niche in PT, you might find that you want to seek continuing ed in some of these areas. And actually, at the end of March, I'm going to be going to a vestibular examination and treatment workshop, and I'm really looking forward to it because I think it'll be interesting. So vestibular disorders, besides vertigo, they can also cause pathologic nystagmus, and we talked about that in the vision chapter, unsteadiness, ataxia, nausea, and vomiting. So unfortunately, a side effect of vestibular examination can often be nausea and vomiting because you're trying to duplicate provoking symptoms. So it's pretty common to have someone vomit or at least get nauseous during a vestibular evaluation. So peripheral vestibular disorders typically cause recurring periods of vertigo accompanied by moderate to severe nausea. Nystagmus almost always accompanies peripheral vertigo, and certain drugs can also cause peripheral problems. So one of the examination tools that is used, it's a set of infrared goggles, so you can, and really you end up with on your screen a giant picture of that person's eye, so as you move them through different positions, you can see very minutely any nystagmus that results from those positions. And I think I have a video in the module. If I don't, I'll find one and put it in there. So BPPV, or benign paroxysmal positional vertigo, is an inner ear disorder that causes acute onset of vertigo and nystagmus. So we'll break down the name of it. Benign means it's not malignant. Paroxysmal, sudden onset. Positional, it's caused by changes in head position. So head position changes are the provoking stimulus. So with BPPV, a rapid change of head position results in vertigo and nystagmus, and it subsides in less than 2 minutes, even if you hold the provoking head position. So BPPV is commonly treated in outpatient PT, and the nice thing is people respond really well to the treatment, and so they get relief within 1 or 2 sessions, which is great. And we can teach people how to self-treat at home as well. So it's something that a lot of people have, and unless their doctor tells them, a lot of times they don't know that they can get simple treatment in PT for it. So let's spread the word on that. If people have BPPV, go to your vestibular specialist PT and get some treatment and get some relief. So activities that frequently provoke BPPV are getting into or out of bed, so that moving from vertical to horizontal and rolling. Bending over to look under a bed, or like bending over to look into the dryer or something like that. You're going to get your clothes out. Reaching up to retrieve something from a high shelf. Your head tilts back often when you do that. And turning over in bed. That's that rolling movement. So BPPV symptoms are caused by displacement of otoconia from the macula into a semicircular canal. So normally the otoconia are like the nuts on top of the jello, and the nuts fall off and they get loose in the semicircular canal. So as they're rolling around in the semicircular canal, they cause those intrasensory conflict symptoms and cause vertigo. So basically you have rocks in your head. And the treatment that we do is a series of movements to get the otoconia back into the right place. Pretty neat, right? So take a look at some of the videos in the module where you can see the 3D version of this, and you can see how the movements roll the otoconia back into the right place. Vestibular neuritis is an inflammation of the vestibular nerve, usually caused by a virus. So since it's a virus, it usually resolves on its own as well. And the symptoms include disequilibrium, spontaneous nystagmus, nausea, and severe vertigo for up to 3 days. Usually hearing is unaffected. Testing shows decreased or absent response on the involved side. It's usually just one side versus the other. So you get those intrasensory or intersensory conflicts that cause the symptoms. During the acute phase, medication might be used to suppress nausea, vertigo, and vomiting. So vestibular neuritis can be pretty debilitating, but luckily you do get better from it. Meniere's disease, it is idiopathic. They're not really sure what causes it. It causes sensation of fullness in the ear, tinnitus, which is ringing in the ears, severe acute vertigo, nausea, vomiting, and hearing loss. And unfortunately, the hearing loss in Meniere's disease is irreversible. It's associated with an abnormal fluid pressure in the inner ear, but it's not certain whether the abnormal fluid pressure causes the problem or is an effect of the problem. So it's one of those idiopathic things where they're not sure why it happens. Often drugs that suppress vertigo are useful during acute attacks. In extreme cases, they will surgically sever the vestibular nerve to relieve symptoms. That doesn't do anything for the hearing loss, but it relieves the symptoms of vertigo and nausea and tinnitus. So perilymph fistula. Perilymph is the fluid in the space between the bone and the membranous labyrinth in the inner ear. A fistula is basically an opening where there shouldn't be an opening. So perilymph fistula occurs when you have an opening between the middle and inner ear, allowing the fluid to leak from the inner ear to the middle ear. It causes an abrupt onset of hearing loss with tinnitus and vertigo. Usually perilymph fistula is caused by trauma and it requires surgery to correct. So traumatic injury of any sort can cause concussion of the inner ear, fractures of the bone surrounding the vestibular apparatus and nerve, and pressure changes in the inner ear. So any traumatic injury involving any of these structures can compromise vestibular function. So the vestibular system has two roles in motor control. It contributes to gaze stabilization through the vestibular ocular reflex, and it contributes to postural adjustments. So that sort of explains the vertigo and the unsteadiness when you have a problem with the vestibular system, and these things aren't happening. So we talk about peripheral vestibular disorders. When you have central vestibular disorders, the peripheral structures are intact, but there's damage either to the vestibular nuclei or connections within the brain. So typically, you should know this, central vestibular disorders produce milder symptoms than peripheral disorders. So that you will have symptoms, but they are milder than the peripheral symptoms. Central vestibular disorders are commonly the result of ischemia or tumors in the brainstem or cerebellar region, or cerebellar degeneration, multiple sclerosis, or Arnold-Chiari malformation, which is where the brainstem comes out through the foramen magnum. So with central vestibular disorders, there's not a lot that we're doing in PT to change these. Some of these, except for habituation and compensation. So a lot of times in PT, we might be working on remediating a problem. As with BPPV, we're working on remediating the problem. In the case of a central vestibular disorder, a lot of times we're working on compensatory strategies because remediation is not possible. So one of the central disorders is persistent postural perceptual dizziness, and the nickname for it is 3PD. So PPPD, 3PD. And it's dizziness or unsteadiness that persists for more than 3 months, and it's worst with upright posture. It's aggravated by either the motion of the person, their environment, or increased visual demands. So people that I've worked with post-concussion syndrome, if it's severe, can have this 3PD. Something like sitting in a lecture hall and looking at a PowerPoint on a screen can provoke, because that's a visual demand, more than a usual visual demand. Being in a busy place where things are moving around a lot, being in a moving vehicle. So a lot of times, certain events precede 3PD. Vestibular disorders, whether they're peripheral or central, mild traumatic brain injury, so there's our concussion. Anxiety disorders can cause this, depression, and medical problems or medications that cause dizziness or unsteadiness, and there's a whole slew of those. So, unilateral vestibular loss causes problems with posture, eye movement control, and nausea. Signals from the damaged side are not correctly balanced with signals from the intact side. Remember, we said we needed that reciprocal input in order to have that balance, and when you have unilateral vestibular loss, you don't have that. A peripheral lesion interfering with otolithic function on one side causes imbalance. Information from otoliths on the normal side aren't balanced by information from the lesion side. So it affects the vestibulospinal system, producing a tendency to fall towards the side of the lesion. Bilateral vestibular loss. So either you have bilateral loss of otolith input or bilateral effects in the central system. It eliminates the person's internal sense of gravity. So that just makes it so we have to rely more on visual and proprioceptive cues for spatial orientation. It can create difficulties walking in the dark because then we're taking out the visual too, or walking on uneven surfaces. So there's no asymmetry of the vestibular information, so you don't get any vertigo with bilateral vestibular loss. So it's sort of, I like to think of vestibular input, visual input, and proprioceptive input as being like a three-legged stool for balance. So if you take out one of those legs, the stool is unbalanced. Any one of them. So if you lose your vision, it's difficult to orient. If you have bilateral vestibular loss, it's difficult to, you don't have that internal sense of gravity. If you take out you have peripheral neuropathy and you take out the peripheral input from proprioception, then you're more dependent on your vision and your vestibular in order to balance. So you can obviously function with one of these losses, but it just makes it that much more difficult. So a lot of times in therapy, we are working on compensatory strategies. The next section is going to be really short on evaluating the vestibular system.